Hello everyone, welcome to the 2021 CCS Cardiac Surgery Trainee Review course. My name is Marina and I did my cardiac surgery residency training at McGill University, followed by 2 years of advanced aortic fellowship at University of Toronto, and that's what I'm doing right now. So today I'm going to be talking about pericardium, tumor, and trauma. A very heavy topic, especially for the pericardium, involving a lot of hemodynamics understanding, but I'm going to try to simplify it as much as possible, making it as simple as possible for your exam, and pretty much what you need to know is what's on the slides. Starting off with pericardial diseases, today we're going to be talking about pericardial effusion, tamponade, and signs on the echocardiogram and hemodynamic signs of pericardial tamponade. Then we're going to be talking about constrictive pericarditis and the differences between constrictive pericarditis and restrictive cardiomyopathy. Very important topic, comes on the exam almost every year. Then we're going to be talking about tumor pericardium. So first case, 67-year-old male, treated for stage 2 thymoma, status post-thymectomy and radiation therapy. He returns with fatigue, dyspnea on exertion, and peripheral edema. On exam, he is hypotensive, tachycardic with an elevated GVP. S3 sound is present, and he has decreased breath sound. So this is his chest x-ray. It shows, as you can see, a widened mediastinum and left pleural effusion. Most likely diagnosis here is obviously pericardial tamponade due to his either malignant effusion or radiation-induced pericarditis effusion, given his history of cancer and radiation therapy. So what are the causes of pericardial effusion or tamponade? Many causes. This would include iatrogenic invasive procedures in the cath lab or post-cardiac surgery, trauma, neoplasm, infectious, inflammatory, radiation-induced, you name it. What are the clinical findings of pericardial tamponade? So, as you all know, the Beck's triad, here's a nice mnemonic, 3Ds, decreased arterial pressure with narrow pulse pressure, distended jugular veins, and distant hard sounds. Pulsus paradoxus. I'm going to give you more explanation in the next slide, which is basically inspiratory decrease in systolic blood pressure more than 10 millimeters of mercury during normal breathing. And patient also presents with shortness of breath, fatigue, peripheral edema, ascites, hepatomegaly, and pleural effusion. So what is the reason why pulsus paradoxus happens? So during inspiration, the negative intrathoracic pressure results in an increased right venous return, filling the right atrium more than during exhalation. So then the increased blood volume dilates the right atrium, reducing the compliance of the left atrium due to their shared septum. And then lower left atrial compliance reduces the left atrium venous return, and as a consequence causes a reduction in left ventricular preload. This results in a reduction in left ventricular stroke volume, and this will be noted as a reduction in systolic blood pressure during inspiration, and hence pulsus paradoxus is an exaggeration or an increase in the fall of systolic blood pressure beyond 10 millimeters of mercury during inspiration. However, during normal inspiration, a person's systolic blood pressure decreases by less than 10 millimeters of mercury, and the heart rate slightly increases. Another sign here on the electrocardiogram, you can see electrical alternance, which is alternation of QRS complex amplitude or axis between consecutive beats, and you can very obviously see low voltage QRS. So, very, very important for your exam. You have to memorize the slide. What are the echocardiographic signs of pericardial tamponade? Those are very easy points for the exam. You have right atrial compression, RV, early diastolic collapse. The next two, I wouldn't necessarily write them on the exam unless they ask you for 7 signs. Left atrial collapse during systole, less common but an accurate sign for tamponade. LV collapse during diastole, rare but can be seen in regional tamponade post-cardiotomy. Exaggerated inspiratory flow velocity variation on pulse wave Doppler with increase in tricuspid and pulmonic and decrease in mitral and aortic velocities. This is again because, as we explained earlier, during tamponade things are exaggerated, and during inspiration there is more return across the tricuspid and pulmonic valves, and hence you get an increase across the tricuspid and pulmonic velocities and decrease across the mitral and aortic velocities. Then you have an inspiratory shift of the interventricular septum towards the left, and this is pretty straightforward. The explanation, as we explained earlier, you have the shift of the interventricular septum towards the left because there is more return to the right side during inspiration. And then you also have dilated IVC and hepatic veins. This is a reflection of elevated right atrial pressures with an IVC diameter more than 2 centimeters, and IVC does not collapse by more than 50% with inspiration. These are all images. This is a subcostal view, and you can see here pericardial effusion causing RV collapse. Next image, you can see very clear right atrial diastolic collapse. And you can see here complete collapse of the right ventricle. So again, this is an echocardiographic image showing a 4-chamber view pulse wave Doppler at the mitral inflow, with showing significant respiratory variability. Again, with decrease in the mitral inflow velocities during inspiration. So the 2015 European guidelines recommend transthoracic echocardiogram as first imaging technique if there is clinical suspicion of tamponade. This is a class 1, and urgent pericardiocentesis or cardiac surgery is recommended for treatment of pericardial tamponade, and obviously avoid vasodilators and diuretics. So what is the management of pericardial tamponade? It can either be through needle pericardiocentesis, echocardiographic or fluoroscopic guidance, and or surgical drainage using a pericardial window, subxiphoid usually, or mini thoracotomy with VATS or sternotomy. So surgical drainage is preferred in these situations if there is a recurrent malignant effusion despite multiple needle pericardiocentesis, purulent pericardial effusion, traumatic or iatrogenic tamponade with suspected bleeding, or post-cardiac surgery, though actually I've seen a lot of post-cardiac surgery tamponades being treated with needle pericardiocentesis, and this is in the case of Dressler syndrome. So constrictive pericarditis. Now, what is constrictive pericarditis? Constrictive pericarditis is basically encasement of the heart by a thickened, fibrous, and sometimes calcified pericardium with secondary abnormalities in chamber filling. The pericardial fluid is generally absent or of normal volume. The wall of the pericardial sac is usually thickened with 3 to 20 millimeters thick, as opposed to a 1 to 2 millimeter thickness of normal pericardium. Pathophysiological hallmark: impaired diastolic filling of ventricles later in diastole. And classic clinical picture: right heart failure with preserved right ventricle and left ventricle systolic functions in the absence of previous or concomitant myocardial disease. And obviously patients will be presenting with signs that are very similar to tamponade, including fatigue, peripheral edema, shortness of breath, ascites, jugular venous distension, hepatomegaly, pleural effusion. Constrictive pericarditis causes, also many, could be radiation induced. This is the most common cause in North America. Idiopathic causes: neoplasm, ischemia, Dressler syndrome, post-MI pericarditis, cardiac surgery post-cardiotomy, collagen vascular disease, drug-induced sarcoidosis, and uremic pericarditis. So it's primarily a disease of the pericardium. It's really important to remember. Types of constrictive pericarditis. So we have transient, effusive, and chronic. Transient constrictive pericarditis is reversible, and patients will usually take a 2-3 months course of empiric anti-inflammatory medical therapy, and hopefully then it regresses with medical therapy. The effusive type, you will see failure of the right atrial pressure to fall by 50% or to less than 10 millimeters of mercury after the pericardiocentesis. Pericardiocentesis usually is the treatment followed by medical therapy, and if it's still persistent, then pericardiectomy will be the treatment. Then for the chronic type, then you'll have persistent constriction after 3 to 6 months, and pericardiectomy with medical therapy will be the long-stay treatment. So again, in terms of the management of constrictive pericarditis, class 1, Treatment is a pericardiectomy, recommended as the mainstay of treatment for chronic constrictive pericarditis, and medical therapy is recommended for specific forms of pericarditis, the transient type, for example, TB, to prevent progression of constriction. And anti-inflammatories are a class 2B indication, and again, they may be considered for transient constriction or new diagnosis of constriction with a concomitant evidence of pericardial inflammation. So, pericardiectomy is the treatment of choice for chronic pericardial constriction. Again, as we mentioned, class 1 recommendation, and operative mortality is actually quite high, 6 to 12%. The principles of surgery will involve complete excision of all anterior pericardium between the phrenic nerves and excision of posterior pericardium around its reflection on the SVC, IVC, and the pulmonary. So to the very important topic for your exam, constrictive differences between constrictive pericarditis and restrictive cardiomyopathy. So as the name states, constrictive pericarditis is primary disease of the pericardium, in which the heart is encased by thickened, fibrous, and sometimes calcified pericardium, and the treatment is surgical with pericardiectomy for chronic constrictive pericarditis. However, on the other hand, for restrictive cardiomyopathy, this is a primary disease of the myocardium that is characterized by increased myocardial stiffness, resulting in a rapid rise in ventricular filling pressures, reflected in both the systemic and pulmonary circulations. And despite marked abnormalities in the diastolic function, the left ventricular ejection fraction is typically preserved, and the treatment is medical. This is a really, really nice paper. You should really read this paper, and then you're going to know all about everything about the differences between constrictive pericarditis and restrictive cardiomyopathy. Okay, now to this very important slide. Before I start with the hemodynamic explanation of the difference between constrictive pericarditis and restrictive cardiomyopathy, I'd like to tell you that over the next few slides, I'll list out both the echocardiographic and the hemodynamic differences between both restrictive cardiomyopathy and constrictive pericarditis, and you absolutely have to memorize them for the exam. And now for the explanation. So the top part here represents constrictive pericarditis, and here in constrictive pericarditis, there is rigid cardiac encasement that has the additional effect of isolation of the cardiac chambers from swings in interthoracic pressure. So with inspiration, there is reduction in interthoracic pressures that are not fully transmitted to the cardiac chambers. Because the pulmonary veins are interthoracic, so inspiratory reduction in pulmonary, capillary, and venous pressures will reduce the flow between the pulmonary veins and the left-sided cardiac chambers. So there is less flow into the pulmonary veins and less flow to the left side of the heart. And in the setting of a non-compliant pericardium with a relatively fixed intrapericardial volume, there is reduced LV filling, and this allows increased RV filling. So you can see here, there is actually reduced LV filling, and there is increased RV filling. And this is accompanied by inspiratory intraventricular septal motion towards the left side. And there's increased inferior vena cava flow during inspiration that is augmented by increased transdiaphragmatic pressure competing with flow from the SVC into the high pressure right atrium. So on the other hand, with expiration, there is a rise in interthoracic and therefore pulmonary venous pressures. This augments flow into the left side of the heart, so there is more flow under the curve of the left ventricle here, and there's increased left heart filling with a fixed total intrapericardial volume, pushing the intraventricular septum here towards the right, because there is interdependence of the intraventricular septum, because there's really no space for it to go. As we had explained, there is rigid encasement of the free walls of the right and left ventricles by the rigid pericardium, and there is septal interdependence because there is no other space for it to go. So increased left heart filling here within a fixed total intrapercardial volume pushes the intraventricular septum towards the right, reducing the RV filling and creating expiratory diastolic flow reversals transmitted back to the inferior vena cava and hepatic veins. This respirophasic hemodynamic augmentation is an important and specific feature of the constrictive physiology. Increased ventricular interdependence directly translates to alteration in ventricular systolic pressures. Although these pressures rise and fall in parallel with respiration in normal physiology, as you can see here also in terms of restrictive cardiomyopathy, they don't in constrictive pericarditis. And this is a marker that is both sensitive and specific for constrictive pericarditis. However, in restrictive cardiomyopathy, here we see no evidence of enhanced intraventricular dependence, and there are parallel changes in the LV and RV pressure curve areas. Increased venous flow with inspiration is unable to be accommodated by a non-compliant RV. Hence, there's diastolic flow reversal in the hepatic vein with inspiration. However, unlike constrictive pericarditis, there is no discordance of intracavitary and intrathoracic pressures, and there's no evidence of enhanced ventricular interdependence with parallel changes in LV and RV pressure curve areas, as you can see here in the diagram. And as you can see here, the square root sign is present in both tracings, and it's not a reliable finding to differentiate constrictive pericarditis and a restrictive cardiomyopathy, so I would not write that sign. So here for this slide shows simultaneous LV and pulmonary capillary wedge pressure hemodynamic assessment. So which one here do you think is representing constrictive pericarditis and which one is representing restrictive cardiomyopathy? So the first one here is representing constrictive pericarditis, because in constrictive pericarditis there is decrease in the pulmonary capillary wedge pressure, LV diastolic pressure gradient during inspiration, and an increase in the gradient during expiration for the same reasons that we had explained earlier. And this is because of the dissociation of the intrathoracic and intracardiac pressures. Again, in restrictive cardiomyopathy, there is no respiratory variation in pulmonary capillary wedge pressure and LV diastolic pressure gradients, demonstrating normal association of the intrathoracic and intracardiac pressures. Okay, and now here we'll come to the very important slides that you are absolutely supposed to memorize for your exam. So these are the echocardiographic differences between constrictive pericarditis and restrictive cardiomyopathy. So again, for all the reasons we explained earlier, constrictive pericarditis, you have that septal bounce that's representing the ventricular interdependence, this is because impaired right and left ventricular free wall strains relative to the septal strain. As we said, the heart is encased by rigid pericardium, and there is nowhere for the free walls of the right and left ventricles to go, and it's only really the septum that moves. So that's why on the echo you see that septal bounce. The second point is enhanced ventricular interdependence, and you see that during inspiration and exhalation. So during inspiration, as we had explained, there is less flow through the left side of the heart because the pulmonary veins are intrathoracic, so there's less flow through the pulmonary veins and less flow through the left side of the heart. Hence, that means there will be more flow through the right side of the heart, and the septum will shift towards the left, and your systolic pressures will decrease. Finally, there's discordant respirophasic ventricular systolic pressure changes. In restrictive cardiomyopathy, there's no septal bounce, there's no enhancement of ventricular interdependence, and there's concordant respirophasic and ventricular systolic pressure changes. and there's marked by atrial enlargement. Again, these are the hemodynamic findings. So in constrictive pericarditis, there is enhanced ventricular interdependence with disconcordant respirophasic ventricular systolic pressure changes. There's dissociation of the intracardiac and intrathoracic pressures. There's equalization of the right and left filling pressures, where the left ventricular end diastolic pressure minus right ventricular end diastolic pressure is less than 5 millimeters of mercury because of the rigid encasement of the pericardium of both ventricles. And the right ventricular systolic pressure is less than 50 millimeters of mercury. However, in restrictive cardiomyopathy, there's no evidence of enhanced ventricular interdependence. There's concordant respirophasic ventricular systolic pressure changes, and there's normal association of intracardiac and intrathoracic pressures. And the left side filling pressures are higher than the right side, with left ventricular end diastolic pressure minus right ventricular end diastolic pressure is more than 5 millimeters of mercury because of the diastolic dysfunction, and this causes marked pulmonary hypertension. So the right ventricular systolic pressures end up being really high, more than 50 millimeters of mercury. So just memorize these two slides, and you will be good exam. So now talking about tumors. So cardiac tumors, this is sort of an important topic for the exam. Probably get 1 or 2 questions, but it'd be a shame to miss one or two straightforward questions. So I suggest you just memorize the coming slides. Not very difficult to memorize. So primary pericardial tumors, 75% of which are benign and only 25% of which are malignant. And then there are the secondary tumors. It usually comes from metastasis. It could also be confused for thrombus or vegetation. So secondary cardiac tumors are 20 to 40 times more common, and malignant primary cardiac tumors are really uncommon. So memorize this slide. Benign primary cardiac tumors. In adults, Mixoma is the most common. Lipoma is the second most common. Then you have papillary fibroelastoma and hemangioma. In children, the most common is rhabdomyoma, very common question on the exam, then followed by fibroma, myxoma, and intrapericardial teratoma. So what do you think this one is? This is a myxoma, lefty myxoma. So myxoma is a pedunculated mass with stalk attached to the intraatrial septum. This is actually what we most commonly see in the operating room, and this is made out of mesenchymal connective tissue. 90% of the cases is sporadic, most commonly found in the left atrium and less commonly found in the right atrium, and 5 to 10% of which are familial. So why is surgical resection recommended? Because of the high risk of associated cardiovascular morbidity and mortality. They can most often embolize into the systemic circulation or into the coronary arteries. It can also cause mechanical intracardiac obstruction because they can be really big, and they could cause valvular dysfunction, causing regurgitation, stenosis, or acute obstruction. So this case, 32-year-old female referred for masses in the heart, along with some cutaneous lesions. What do you think this is? This is carny complex. So you see multicentric cardiac masses here on the echo, consistent with cardiac myxoma associated with cardiac. So carny complex is a rare inherited autosomal dominant disorder with multiple neoplasia syndrome. Mutation is in the PRKAR1A gene. I suggest you memorize this gene. Most commonly, you find non-cutaneous lesions with cardiac myxomas in 20 to 40% of all patients. 7% of all myxoma cases are related to carny complex. So features of carny complex, you have skin lesions, as we had seen in the picture, the cutaneous lesions. You also have pituitary, they're associated with pituitary tumors and Cushing syndrome, cardiac myxomas, and adrenal tumors. So myxoma, as we had said, could be sporadic or familial, and it's important to know the differences between both. So in sporadic myxomas, they're most commonly found, this is the most common type, 90% of the time, and it's found in the left atrium, 75% of the time, followed by the right atrium. And they're more frequent in females. The mean age of diagnosis is 55%. The mean age of diagnosis is 55 years. And there is a 1 to 4% chance of recurrence after resection. For the familial type, they're autosomal dominant, can occur anywhere in the heart, in the atrium or ventricle, and they have equal occurrence in both males and females, and the mean age of diagnosis is 25 years. Recurrence after resection is 20 to 65%. This slide is important because on the exam they can ask you what's differences between sporadic and familial myxoma. What do you guys think this is? This is a papillary fibroelastoma. So papillary fibroelastoma, it's a benign cardiac tumor that is primary, resembles sea anemone with front-like projections, as you can see in the picture. Most commonly attached to valves. AV valves and semilunar valves are equally affected, with solitary 90%. So papillary fibroelastoma is usually asymptomatic until a critical event like flow obstruction, particularly coronary ostial flow, or systemic embolization like stroke. Surgical resection is recommended whenever it's diagnosed because of the risk of embolization, and recurrence after resection is about 1 to 2%. And it could be also associated with some valve repair that is required if it's causing some valve regurgitation or so. Cytomegalovirus is sometimes found in the tumor mass, so it's associated with the cytomegalovirus. So what is this? This is the most common primary cardiac tumor in children. This is rhabdomyoma. This instance about 50%. Most common presentation is heart block or other arrhythmias. On echocardiogram, it's diagnosed. It looks like multiple small lobulated homogeneous hyperechoic intramural tumors. It's associated with spontaneous regression in most cases. Sometimes it needs surgical resection, and surgical resection is reserved for refractory arrhythmias or severe hemodynamic compromise that is caused by obstruction, for example. So the malignant cardiac tumors, they're rare. Malignant primary tumors present 25% of the cases, and those are the types. And malignant secondary tumors are obviously metastatic, and these are the types. Primary malignant cardiac tumors have a very poor prognosis, and extracardiac metastasis at time of diagnosis is actually very common. Things to consider when contemplating surgical resection: you have to make sure there's no metastatic disease. And when you think about resectability, think about the size, the location, extent of involvement of myocardium and or fibrous skeleton of the heart, and the histology. A role of complete resection is limited to providing better palliation, potentially doubling survival. So angiosarcoma, more common in men, most commonly found in the right atrium. Extracardiac metastasis presents in 75% of patients at diagnosis. Median survival 6 to 12 months. Without resection, 90% of patients die within 9 to 12 months of diagnosis despite chemotherapy. Secondary metastatic malignant cardiac tumors. 10 to 20% of all extracardiac metastatic tumors eventually reach heart or pericardium. More common than primary malignant cardiac tumors, as we had said. Role of surgery is limited to palliative relief of recurrent pericardial effusions or tamponade, and this would involve a subxiphoid pericardotomy or pericardial window or rhabdomyoma. So, and those are the tumors of the pericardium. Here I'm listing the names of the benign primary tumors, malignant primary tumors, and malignant secondary tumors of the pericardium. And here are the mediastinal masses. So now moving on to our final topic. So cardiac trauma comes in two forms: blunt cardiac injury, penetrating cardiac. So blunt cardiac injury, most common is myocardial contusion. It could present as clinically silent to severe myocardial dysfunction. It could also have pericardial injury and blunt cardiac trauma. And this could be because of high energy impact or fast increase in intra-abdominal pressure, leading to herniation of the heart into the abdominal thoracic cavity. This can lead to torsion also of great vessels. You can also have valvular injury in blunt cardiac trauma. This would involve the aortic and mitral valves most commonly, and they can rupture or tear due to compressive forces of blood during contraction. You can also have coronary artery injury. This is extremely rare. Dark blunt injury causing dissection or thrombosis. LAD is the most commonly involved because of its anterior location. You can also have cardiac chamber rupture causing tamponade, and this usually presents with prominent hemodynamic instability. Then moving on to penetrating cardiac injuries. It's one of the leading causes of traumatic death in urban settings. Most often, these patients don't present to the hospital. RV is most commonly injured. 5% have associated coronary artery laceration. Two major causes of mortality: cardiac tamponade or exsanguinating hemorrhage. So the cardiac box, as you all know, from the sternal notch up to the xiphoid process between both nipples. Stab or gunshot wounds may lead to perforation of the cardiac chambers, any of the cardiac chambers, coronary artery, or great vessels. Gunshot wounds, bullet can often have unpredictable trajectory, especially if there's no exit. So in terms of the management, obviously you do your ABCs as per the ATLS protocol. And you can have three types of patients. In extremis, were patients who come in with active CPR on arrival, unstable patients who are responsive to initial resuscitation attempts, and stable patients where you can have the cardiovascular injury revealed on survey. So in terms of management of patients in extremis who come with a CPR on arrival, so for these patients, you can do an ED thoracotomy. If a patient comes with penetrating trauma and has been having ongoing CPR for less than 15 minutes. However, if it is a blunt trauma, you can do an ED thoracotomy if CPR has been ongoing only for less than 5 minutes, because patients with blunt trauma are less likely to have an injury that can be salvaged by ED thoracotomy. And these patients have to present with signs of life, and signs of life would be pupillary response, respiratory effort, or motor activity. And here's an algorithm here that was published. You can take a look through the algorithm if you want. So in terms of management of unstable patients, so the cause of the hemodynamic instability usually is identified on secondary survey, and these patients are usually responsive to initial resuscitation. So the decision of whether or not to do ED thoracotomy versus take the patients to the OR, obviously the preferred option is always to take the patient to the operating room if they're responsive to resuscitation. I would definitely take the patient to the operating room because it's a much more controlled setting there. Doing an ED thoracotomy in the emergency department is could save the patient's life sometimes. However, it's a total mess most of the time, and much better to take a patient to the operating room because you don't have much instruments or suction or anything in the emergency department. So you can also do a needle pericardicentesis in the emergency department. Extremely rare that anybody would do that, and it's again not really a controlled setting. Much better if the patient is responsive to resuscitations, take patient to the operating room for a subxiphoid window. So again, those are pictures of subxiphoid window. And ED thoracotomy, usually go left anterolateral thoracotomy in the 4th or 5th intercostal space. And the exposure, you see the heart, the lungs, the descending aorta, and the esophagus. You might miss the esophagus, obviously, if there's no NG tube. May be extended to clamshell incision as well. So potential interventions that you can do, you can push the lungs out of the way and cross-clamp the descending aorta for abdominal hemorrhage, and this maintains cerebral and coronary perfusion, facilitates fluid resuscitation. That can definitely save the patient's life. And if you can see the bleeder, you can do direct control of the bleeding. And you, again, if you lift the lungs out of the way, you can do pericardotomy, and this could relieve tamponade. And you can also clamp the pulmonary hilum for pulmonary hemorrhage, air embolism, and do single lung ventilation. You can do also open cardiac massage and internal defibrillation. So all sorts of options there. Those are pictures of ED thoracotomy. You're cross-clamping the aorta. You can see here you're pushing lungs out of the way. This is the heart pericardium, and this is here the aorta being cross-clamped. This is your spine. Again, here as you can see the phrenic nerve, and you're doing a pericardotomy to relieve tamponade. Here clamping the pulmonary hilum. You opened up the infrapulmonary ligament and clamping the pulmonary hilum. So finally, there's a ventricular laceration that's adjacent to a coronary artery. It can be repaired with pledged horizontal mattress suture. However, if it's right around the coronary artery, it's important to pass the needle deep into the myocardium and under the coronary artery to avoid obstruction of coronary blood flow. So that's it for pericardium tumor and trauma, and those are the suggested readings. I wish you all good luck on your exam. It's very important to memorize the slides that I highlighted, especially the ones stating the echocardiographic signs of tamponade and the differences between constrictive pericarditis and restrictive cardiomyopathy, both the echocardiographic and the hemodynamic signs. They almost always come on the exam, and for pericardial tumors as well, the slides that I highlighted to memorize. That's it. Thank you very much, and good luck on your exam.